I'm going to help Joe out with this. Joe's going to, come in and pitch out with this. And these are his slides, but I'm going to try to make the best of them and move forward. So just like cardiac arrest, the chain of survival is very important. And we need to make sure that we have early detection of a stroke, early dispatch of a stroke, and early delivery of EMS and getting that patient to the emergency room. That's why you see a bunch of ad campaigns out there for FAST exam, right? The American Heart Association puts out things, signs and symptoms of a stroke. And there's a bunch of pamphlets out there, and stroke education to the community is really big. We need to detect it. And we need to make sure that people who have headaches or who have, weird numbness going on in their body, that they just don't blow it off thinking they slept on their leg the wrong way. With that, hopefully 911 centers will be able to go ahead and do emergency medical dispatching in order to identify the stroke. Because if we know going in as EMS it's a stroke, then we know that we already have the clock. The clock started from when their symptom presided. And then delivery of that patient to the emergency room. And then getting them to the door and door to balloon time. You're going to hear in my part of the lecture later on in my PowerPoints, we're going to talk about endovascular thrombectomy and why that's important. And then just like if we activate the cath lab for a STEMI, we're going to try to activate the interventional radiology lab at a comprehensive stroke center for a stroke. Locally in the Mahoning-Trumbull County area, we don't have a comprehensive stroke center. The closest one would be Cleveland. Cleveland has 2 of them, I believe. Pittsburgh has another one. But what we can do is we can get them to a primary stroke center, and we can advise them that they have a stroke going on, and they can fly them out if they need to. Every stroke in every hospital and every sort of like disease has data, and that's how we guide what's going on with our patients and how we guide what treatments are happening. And then, what do we do for this patient? The decision. Do we, give them TPA in the hospital, in the emergency room, and then see if they have a small lacunar stroke, and then that would they be able to go ahead and dissolve the clot? Do we fly them to the comprehensive stroke center and let them do endovascular thrombectomy, where they actually put a stent in and pull that clot out? And then we want to see how the patient ended up. So, of course, this is what I already said: good public recognition and EMS access, rapid dispatch of EMS, rapid recognition for our providers, EMS, stabilization of the vital functions, rapid transports, and then let the facility know early on, I have a stroke alert. I have a stroke alert. I want to make sure that ER nurse or whoever answers the phone knows they better have CAT scan ready when you walk in. Most strokes occur at home, right? And patients minimize or rationalize symptoms. I just slept on my arm the wrong way. That's why it's numb. That's why I can't move it. And I think we've all kind of had our leg fall asleep or our foot fall asleep. It's like, oh, I just got to move it. But what happens after 5 or 10 minutes and that movement doesn't get better, or that tingling sensation doesn't get better? That's a sign of concern. And everybody says, you know what? It's not a stroke. It's not a stroke. I know that can't happen to me. My own mother had facial numbness and tingling, and I was talking to her, and her left lip drooped. I'm like, Mom, I think you need to get you to the hospital. No, I'm not having a stroke. You don't know what you're talking about. I said, Mom, I went to medical school. I'm pretty sure I know what the hell I'm talking about. And I've been a paramedic, since 2008. I'm pretty sure you need to listen to me. My own mother doesn't listen to me when I think she needs to go to the hospital. So why is somebody else going to listen to a complete stranger saying you need to go to the hospital? You're having a stroke. And again, the hospitals have the education through the stroke programs, but we need to make sure that we're being compassionate. And, I'm like my mom. I said, Mom, just do what I tell you to do, because I know more than you. But again, treat them with respect and kindness. Again, 911 centers, they need to ask, certain questions and figure out, with their emergency medical dispatching and their protocols that they have, what's going on with the patient, the first onset of symptoms, and figure out if they have any other medical conditions such as hypoglycemia that might actually, diabetes that might actually contribute to mimic stroke symptoms. And, just maybe say it, brain attack, and, have them talk in plain English, say this patient's having a brain attack if they don't want to use the term stroke. Again, the call taker and dispatch have to work together. And so you might have one person on the radio dispatching the ambulance, another one talking to the patients. And when they type in those complaints, it's loading on the screens. And I know some ambulances in Trumbull County here locally, they have MDTs, and they can see the updates of the calls. And just you're going to assess for, do you have any weakness or numbness in the face, the arm, or the leg? Are they confused? Do they have difficulty speaking? Are they able to understand? Do they have difficulty seeing out of either one, both eyes, their temporal regions, out like peripheral vision, or in the middle by their nose, they can't see medially? Do they have any difficulty walking? Are they dizzy? Any loss of balance, coordination? And do they have a severe headache, which is always termed as the worst headache of my life? The definition of a stroke is an acute neurological impairment that follows interruption of the blood supply to a specific region of the brain. So what we see here is I'm going to move this out of the way. We actually see that in this, let me pick a different color here with my pen, is that this region right here, this is actually, I can tell this is the medial cerebral artery. And the medial cerebral artery is actually going to affect this whole region of the brain. And so over here, you would have your face, you would have some of your hand, you'd have some of the other parts of your body. But what it is this stroke, anything distal from the clot is not going to get perfused. A blood clot will block the flow of blood to that area of the brain, and that's why they're going to have signs and symptoms of paralysis, weakness, facial drooping, some sort of motor component of that. With a hemorrhagic stroke, notice that we don't have any blockages here, but we have some hemorrhaging, and the blood is actually coming out into the from that artery into some of the surrounding spaces. So just as bad as over here, where we actually don't have any blood flow to this area, blood is necrotic to tissue. And if we give blood onto brain tissue that's not in the vascular compartment, it'll actually start to cause necrosis to that part of the brain. So we'll have similar symptoms as if we had an ischemic stroke. As we said, the ischemic stroke is caused by a clot. And so one of the things I want to kind of tease you to early and then wrap up with it later on with my PowerPoint is I want you to focus on these here and these here. Those, maybe that's not the right color since it's blending into the background. These here and this here. And so what happens with those are small vessels, and those small vessels we call lacunar strokes. And those are what we need to treat with TPA in the hospital. I know in Cleveland, they have the Cleveland Clinic Mobile Stroke Team, and they'll actually dispatch an ambulance to rendezvous with a EMS provider with an ambulance, and they'll actually do the CT and start the TPA right there. But here, these are normally caused by hypertension. It's these large arteries here that we worry about when we have a stroke, a large vessel occlusion stroke, and that's something new to us, is because if we take out one of these large arteries right there, we don't have any blood flow to any part of this brain. And that is bad. That is bad. So we actually want to make sure that we can identify later on, is it a lacunar stroke, the small ones, or is it a large vessel occlusion, which is going to be these larger arteries? And ischemic stroke is that clot, and that takes account for about 85% of all strokes. Very rarely do you have death in 1 hour. These patients will have a headache. They'll have signs and symptoms of numbness. It'll progressively get bad and worse as time goes on. And by the time you see the facial droop from the start of the onset, you should have already been at the hospital. We can categorize the ischemic strokes as different classes: thrombotic, embolic. Maybe they have a TIA, a little clot that lodged and then got loose. Maybe it's a reversible ischemic neurological deficit. Maybe it's a hypoperfusion stroke or a cryptogenic stroke. And we're going to get into these. So thrombotic stroke, it accounts for about 60% of all ischemic strokes. And pretty much what that is, you have plaque buildup from a lifetime of, double cheeseburgers and a Diet Coke from McDonald's, and you start to have atherosclerosis and you start to have plaque here. Well, what happens is as the blood is coming through here, it has this little pathway. So what's going to happen is blood is going to come in here, and instead of having a turbulent flow straight through, what's going to happen is it's going to start to spin, and it's going to start to go like that. When that happens, your platelets will start to stick together. And when they start to stick together, they're actually going to start and attach right here on this plaque, and then another platelet's going to attach to that, and another platelet's going to attach to that, and before you know it, you're going to have a clot. And that clot is going to get bigger and bigger. And because this vessel is already narrow, you cause a stroke. You cause distal blood flow disruption, and you're not able to have that area of the brain working. But clots, as you'll see later on, clots can also come from AFib. And the same idea would happen is that if this is going to be, let's draw this here. This is the heart, right? And so this is my left atrium. And so what happens is I have AFib for whatever reason, and those are ectopic cells. So what happens when I start to have these ectopic cells all over the left atrium, instead of blood flow coming straight down in a linear fashion, the blood will actually start to spin. And when the blood starts to spin, you have coagulation. You have platelets sticking together. You form a small clot that your heart is able to pass. But from the left atrium to the left ventricle comes out of the aorta. And that aorta will come off of the aorta. Sorry, let me see here. The aorta comes off like that, and then you're going to have internal carotid or common carotid arteries, and you're going to have your external carotid, and then you're going to have your internal carotid. And this clot that comes out of the left ventricle is going to come up through the aortic arch. It's going to flow upwards, and then it can either take a path, internal or external, and then it can come up and go to the, that's my picture of a brain. And that's what's going to happen, right? So that's one of the things that can happen from a thrombotic clot. So ruptured plaque can also cause this, right? And carotid artery is one of the big things too. Think about back in the day. I know a lot of when I went to school, we were kind of told ways to kind of decrease heart rates. And so one of the things was, you can do the mammalian dive reflex, you can do the Valsalva maneuver, but if you listened well enough and you listened to the carotid and you didn't hear a bruit, well, what the heck's a bruit? It's a whooshing noise of blood going through, kind of go shoo, shoo, shoo. If you didn't hear that, then it might have been safe to go ahead and do a carotid sinus massage. The problem with that is we disrupt plaque. That plaque breaks off. Now you have that floating clot going up, and it lodges into the internal carotid, and it goes and it affects part of the brain. Clots, just like anywhere else in your heart or in your brain, they form from fatty streaks. Okay, and then the streaks will start to build up. So if this is your blood vessel, you're going to have a little bit of atherosclerosis, then eventually you're going to have a little bit more, and then eventually you're going to have a little more. And again, the whole time, what's not happening? You're not getting linear blood flow. And so blood, instead of going straight, is now circling up and going like that. The plaque will become hard. The tunica intima, which is going to be the internal blood vessel lining, is going to weak. And then eventually what may happen is from the turbulence of this blood, you might actually break off part of this plaque, or you might actually rupture part of that vessel. So inflammation of the blood vessel is going to cause ulceration of the plaque, and then it can rupture that. And so what happens is we start to have more platelets stick together. This is your clot. This is your atherosclerosis. That's your plaque. You have more platelets stick together. And then what happens is platelets in primary hemostasis, they stick together by glycoprotein 2B3A, and then they also stick together by TXA2 factor. And then what happens in secondary hemostasis, you start to get the fibrin mesh. And when you start to get a fibrin mesh, that clot and these little platelet plugs are now solid. And what did you just do? You interrupt the blood flow through that vessel. And that's going to be similar for the heart, just as similar it is to the brain. Here we were talking about the layers. I said tunica intima, and these are the different layers of the blood vessels here. But because of cholesterol, you're going to have different fatty streaks, and these fatty streaks will line here in the lining, and then eventually more and more will start to accumulate, and you can see this diameter over here, the sides that get smaller and smaller. We already said that when a diameter starts to get smaller, the blood flow isn't linear, and it starts to go like that. It starts to become turbulent, and then eventually you're going to have a formation of a clot, and then eventually you're going to impair the whole blood flow through, and you're not going to have any blood passage through that vessel. When it comes to an embolic stroke, that's about 40% of our ischemic strokes. It's still blocking part of the vessel, and it's going to cause from a floating clot or a floating, plaque. And so we break that off, and it travels up through the body, up through the carotid arteries, and it lands somewhere in the brain. And again, as I talked about the carotid sinus massage, why that's not done anymore is because one, providers were either forgetting to do listen to the bruits to see if they had any, or they would just go ahead and doing it. And one, it wasn't that it wasn't too effective, and the Valsalva maneuver proved to be a little bit better, and we are causing clots. We're causing strokes. The other thing, we already talked about the AFib. We talked about that the turbulence of blood will have the platelets stick together. It'll form a small clot. It'll go right through the heart, and then it'll land in the small arteries of the brain. And then air can do it too. If we, for some reason, we get air in the line, in our IV line, which takes a significant amount of air, or for whatever reason, there's a hole into the heart or any of the vessels, or somebody comes up and actually has some sort of impaled object into the neck, that's all, we can get an air embolism in that, and it can travel. It can be tissue, it could be fat, whatever it is. Interesting is, we have to be cognizant of fractures. When somebody breaks a bone, typically they could have a stroke, not from the vascular injury of the hypertension and things like that, but by having a fracture of the leg, you actually cause a fat embolism to travel back, and you can actually have that happen. You can have pulmonary embolism if it lands on the right side, or if you have a patent foraminal valley, which is literally, this is your heart, this is your right atrium, this is your left atrium, you have a hole here, and so what happens is instead of blood going straight down, it actually will go straight over and go straight out to your aorta. TIAs, that's what my mom ended up having, was a TIA when she had numbness and a little bit of facial droop, and we finally decided to take her to, well, she let us take her to the hospital. She had a TIA. And what a TIA is a focal neurological deficit, and it's something in the brain that presents like a stroke, but it typically resolves on its own. And it can resolve within a few minutes, and usually doesn't last longer than an hour. So the same thing would apply. It could be either a vasospasm, or it can be some sort of small clot, and that clot will actually just move on throughout the way and get reabsorbed back into the system. Or the vasospasm will actually open back up, and the artery will open to its full diameter, and you'll actually be able to have the symptoms resolve. This is the hardest thing for us to take into the emergency room, because when I come in with a patient, I said, "Doc, they were having a full-fledged stroke, but now you think I'm a liar because they're perfectly fine." Then we need to say patient was having a stroke, take those words and switch them to patient just had a TIA. And that's going to allow that professional nurse or that doctor to kind of like say, "Oh, okay, I get it now," versus, "I swear to God, doc, they were having a stroke, and now I look like an idiot because I walked through the ER and somebody doesn't have any symptoms." Excuse me. When we talk about reversible ischemic neurological deficit, that is a TIA that lasts longer than 1 hour. And that's for a little bit of concern. These patients are going to get, because they present like a stroke, it hasn't resolved in an hour, they're going to get a CT. And because the area of the brain was ischemic for that amount of time, they're going to have some definite evidence of a brain infarction. And they're going to see, if they ever do an MRA or they do some sort of MRI with stimulation, they're going to see that part of the brain that's not working well. And that's going to be the reversible ischemic neurological deficit. When we talk about hypoperfusion strokes, pretty much what that is I don't have brain flow or blood flow to the brain. And so you're going to have a global pattern of brain infarction. Low perfusion pressure or intermittent periods of no blood flow is going to cause the brain to kind of stop functioning. And so you're going to have global left side, right side paralysis, bilateral facial droop, unable to move anything depending on what part of the brain is affected. This could happen after cardiac arrest. Once you do get ROSC and the patient presents like a stroke, well, the brain was hypoperfused for so long that it's going to be considered a hypoperfusion stroke. It can also be in left ventricular wall MI with a pump dysfunction. We know that the left ventricle pumps the blood to the aorta and to the rest of the body, but if I have left circumflex or left common, artery, carotid, left common artery, then that's going to cause some problems as well. Hemodynamically unstable dysrhythmia, so bradycardias or maybe some sort of ventricular rhythms that are not perfusing well. Obviously cardiac arrest, and then hypovolemia or low on fluid is going to cause a hyperperfusion stroke as well. So again, as we already talked about, in an embolic stroke or a thrombotic stroke, you're going to have one certain area of the brain that's not being perfused, and you're going to see later on what part of the brain this acts like. That's going to be most likely the face, and we're going to be able to say, you know what, that's embolic or thrombotic. But when we talk about hypoperfusion, the hypoperfusion is a global area of the brain, and that's going to be usually bilateral, and that's due to decreased oxygen, no blood flow to the brain, no blood flow to any of the to the cerebral arteries, and it presents very. You'll know this when you see this. Finally, we get to a cryptogenic stroke, and that's cerebral ischemia of obscure unknown origin. We just don't know what causes it, but some potential causes could be the AFib. We've already hit on AFib. We also already hit on the patent foraminal valley. So again, this is your heart, this is your right atrium, this is your left atrium, and so right in here you have a hole that just never sealed up. So blood flow, anything that's not linear will cause turbulence of the blood flow. So that blood flow coming in should be straight, but because there's a hole here, you're getting some turbulence here, and then that can cause a clot, and that clot can get bigger, shoot over, and then go down, and then go into your arterial circulation. If we didn't have this hole and you formed a clot, then you get a PE because it would go to the left side of the brain. So again, left side will go to the body, and the right side will go to the lungs. Thrombophilia, that's just platelet disorders. Aortic arch plaque, again, the aortic arch will come off like this, and then it'll break into the subclavia, and then it'll go into the carotids. And so if you have an aortic arch plaque, which is just disrupting blood flow there, you're not going to have any perfusion to the carotids or to the whole brain. Any sort of source of infection and autoimmune disorder could cause that. When we talk about hemorrhagic stroke, that occurs in about 15% of our strokes. So chances are the patient presenting with us is going to have an ischemic stroke. That's a rupture of a cerebral vessel that has some hemorrhage into the surrounding tissue for whatever reason. It could be hypertension. It can be, a blow to the side of the head. It could be anything that causes that to rupture. That's going to cause a hemorrhagic stroke. Direct trauma to brain cells. And what's going to happen is you have the mass effects. You have an increased ICP, intracranial pressure is continuing to rise and rise and rise. And so what happened, there's only so much room you can have in the skull before it actually starts to herniate. And so what's going to happen, the intracranial pressure is going to surround the brain. The brain is actually, there's only one place for the brain to herniate, and it's in the uncus, or that's going to go straight down through the bottom of the skull, right into it's going to compress on itself down into like the spinal cord. And that's going to be a bad day for that patient. When that happens, you obviously have increased lactic acidosis. You're going to have chemical mediators that are going to try to come in. You're going to have failure of the sodium-potassium pump. You're going to have that local vasospasm whenever you have a hemorrhagic stroke, because it's going to vasospasm in order to try to stop the bleeding. But now any other circulation that might be going past that hemorrhage, you're not going to have it because the blood vessel just clamped down on itself, and it's not going to perfuse that part of the brain. You're not going to have cerebral blood flow to distal tissue, as we talked about, and then the edema from the compression of the brain. There's a couple different types of hemorrhagic strokes. Intracerebral hemorrhage, ICH stroke, blood leaks directly from the brain into the parenchyma, and you can see here that it's just leaking out of this middle cerebral artery here, and then it's going in here. This is the lateral ventricle, and so it's leaking in. We can actually see this light up like a Christmas tree on a CT. Small intercerebral arterioles are damaged by chronic hypertension, and usually those are right over there that we'll see. The blood pressures are sustained for so long. We're talking about, hundreds, maybe 160 over 100, and then you just don't take blood pressure medication, or you say, hey, no, I'm fine. I have white coat syndrome. My blood pressure isn't that high at home, but you really don't know. So these lacunar lenticular striate arteries here will start to kind of have so much pressure on them, they're just going to pop. And when they pop, you're going to have blood go into the surrounding tissue. When you have blood go into the surrounding tissue, you're going to have tissue necrosis. A spontaneous cerebral bleed breaks up to about 8 to 11% of all acute strokes. It's more common than the subarachnoid hemorrhage. These have a three-day mortality about 50%, which means 50% of these people die. Higher incidence in men, Asians, and young and middle-aged African Americans. Historically, African Americans have primary hypertension and or essential hypertension, and that's a genetic factor. No matter what you do, you need the cleanest diet. You're not going to get rid of that. Asians are based on lifestyle, and men because, men seem to take higher risks, and historically, I emphasize that historically, blood pressures are up and stress is high because we just don't manage it. With subarachnoid hemorrhage, again, you have layers of the brain, and so what I just want to say, this is your skull. Then what you have is you have 3 layers before you actually get to the brain. You have the dura mater, the arachnoid mater, the pia mater, and then you have your brain tissue. And so what happens is you're going to have a sub means underneath, arachnoid means the arachnoid layer. You're going to have a bleed in here. And so as this bleed gets thicker, what is it doing? It's compressing on the pia mater, which is then compressing on the brain. And then also what goes down has to go up. So you're also compressing on the rest of the arachnoid and the dura mater, and you're causing compression off to the skull. So if you have an arterial rupture, you're going to bleed at the systolic blood pressure rate. It's going to be sudden. It's going to be painful. You're going to have dramatic symptoms. You're going to say, that's the worst headache of my life. Okay. So you're going to have an aneurysm, and that would typically kind of burst open. Typically, these are berry aneurysms. Polycystic kidney disease. That's a problem where you actually have your kidney. It looks like a lima bean. It's not really a lima bean, but then you have all these cysts. So if you have polycystic kidney disease, you most likely have these berry aneurysms on your anterior communicating artery, and you're going to have most likely subarachnoid hemorrhage. You can also have AV malformations. So with AV malformations, on the left-hand side, you're going to have normal capillary beds. You have the artery, you have the vein, and then in here you have the arterioles, which meets with the capillaries, which is right here, which meets with the venules. And at the side of the capillary, that's where you actually offload nutrients and oxygen, and you take on waste products and carbon dioxide and all that stuff from the tissue after it's already used everything. And then it's going to go out. So on the left is normal. On the right, you can see, well, I don't have the same sort of pattern that I have on the left. These are not in parallel. This is what's called parallel, obviously. And this over here is just kind of whatever it wants to be. So I don't have the same amount of pressure on my capillaries as I do over here, right? Things that are in parallel, when we talk about parallel blood flow, parallel means that if I've got 40 millimeters of mercury on this capillary, I have 40 millimeters of mercury there. I have 40 millimeters of mercury there. I have 40 millimeters of mercury there. Here, just by illustration, you can see the center, this center capillary has a lot more flow through it, which is going to affect the amount of pressure going through that. So AV malformations, that's the kind of the small down and dirty pathophysiology behind that. That's why you have difference and variations of pressure in those capillaries, and that's what's causing some to be high pressure, some to be low pressure, and the high pressure is going to be the ones to kind of pop. As Joe already said earlier, in order to have consciousness, you need 2 cerebral hemispheres, or you need the reticular activating system, 1 cerebral hemisphere. So we need that to be processed. We need those to be working in order to have consciousness. Again, this is an illustration of what I drew on the other side. You have your skull, you have the dura mater, the arachnoid, and the pia, and then you have your brain tissue. And again, this will expand. When this expands, you're going to have some blood flow, and you can have some blood spillage out into the arteries as well. In the awake state, ischemic versus hemorrhagic stroke, again, most of these, you're going to see that the carotid artery in your ischemic is going to do anything distal. And when you have the area affected from a hemorrhagic stroke, it's going to be anything that's bleeding. Again, normal brain from the front. And then this is going to be global. This could be like the subarachnoid, where it's going to encompass the whole brain. So again, if we go back to ischemic, we have one portion of the brain. When we come over here, the pia mater goes, or the arachnoid mater, the subdural or subarachnoid mater, that can spread the whole surface area of the brain. So you can have global manifestations via an ischemic stroke, which is probably just going to have motor deficits. When we talk about pathophysiology, the cerebral arteries supply the brain tissue to 2 critical elements. And Joe already hit on this in day 1, oxygen and glucose. And we know that you need those in order to have the sodium-potassium pump working. And the sodium-potassium, because when you have glucose and you have your 32 to 34 moles of ATP, you're going to have enough energy to have that pump work. When you don't have that, that pump's not going to work. So if this is a cell, what you're going to have is normally we want potassium on the inside and sodium on the outside, and this will kind of do that. When this fails, you're going to have sodium come in and potassium be on the outside. And then for every sodium, you get 3 waters with it. And then so what happens, this cell will then decide to swell, and then eventually cell lyses, breaks down, and dies. The normal cerebral blood flow is about 40 to 60 milliliters per 100 grams of brain per minute. And what it does is cerebral blood flow, it encompasses the whole brain. And so that's your cushion for your brain. It actually goes into the folds of the brain. It actually allows neurons to communicate with each other. And it's a cushion. You ever go on a roller coaster, you spin around in a chair and you get dizzy and you feel like you're going to throw up? Well, the reason you feel like that is because the cerebral spinal fluid, not the cerebral blood flow, the cerebral spinal fluid is swishing around and affecting the brain. But let me go back and change what I said. I said cerebral spinal fluid, but should be normal cerebral blood flow is 40 to 60 mLs per 100 grams of brain per minute. All right, and that does your collateral circulation. So you can have different zones of ischemic stroke. You can have a central zone of infarction, and the central zone of infarction is going to be right here. This is the area that the clot's here. It doesn't have any collateral circulation. It's not being perfused by anything else, and that is irreversible. But if you remember from Joe's lectures at the YSU paramedic program, he kept on emphasizing save the penumbra. And the penumbra is this area around here that is savable. This area is supplied by collateral circulation, and that will be what we try to target so we can decrease the amount of deficits this patient has long term. Again, here's a cartoon representation of what's going on. You have your internal carotid artery here breaks out, and then you're going to have your cerebral artery here. You have this stroke, and this area is now done. But all of this over here, this is supplied by 2 arteries, right? You have this and this. So this area is being perfused by the collateral circulation that's coming down, and that's what we aim to try to save, because time is money, and we need to decrease the amount of damage to the brain. So there it is, save the penumbra. So the duration is important. All right, you try to figure out when this patient had the acute onset of the stroke, and if you don't know, what's the last thing they remember? Maybe they remember watching, NCIS the night before, or maybe they remember eating breakfast and putting toast into the toaster. But then when they went to go get the toast out of the toaster, they didn't know how to do it. So we want to kind of get an idea of when this happened. So historically, the time window for TPA, which is tissue plasminogen activator, has been about 3 hours, and that has been what we aim for. And so if you've been running EMS for a little while of time, and I put myself in that category, and I've been doing this since 2008, then that means that we were always told a 3-hour time window, run the strokes red to the hospital, and then you'll be able to hopefully get some TPA. Well, that's been extended, and now with the endovascular thrombectomy and going in and retrieving that clot at a comprehensive stroke center, that 3-hour window might be true for TPA up to 6 hours, and any deficits we should consider them. Up to 24 hours, we should be running these people red to the hospital. The neuroprotective agents or EMS, we need to be able to figure out and ask everything that's going on, right? But also, the penumbra can be damaged by a number of other things. It can be damaged by a seizure, as we talked about. It can be damaged by hypotension, hypoglycemia, hyperglycemia, and a fever, maybe some sort of bacterial meningitis. So what I want you to take away from this is, yes, time is important, but any stroke less than or equal to 24 hours, you should be running red to the hospital. If a patient woke up with stroke-like symptoms, load them in the back of the ambulance and get going to the hospital. They need to run red to the hospital because they need to figure out. We no longer take wake-up or dawn alerts, wake-up strokes. We no longer kind of blow those off because we can't tell. The CT imaging and the MRI is going to figure out how much brain tissue is preserved, is able to be saved, save that penumbra, and get them to the hospital or fly them where they need to go. So the area of the brain preserved by clotted circulation, we said that's the penumbra, but that too will become ischemic and it'll work its way from the inside out. But we can salvage it, both ischemic and hemorrhagic strokes. The penumbra area has a cerebral blood flow of about 10 to 18 milliliters per 100 grams of brain. And again, that's significantly decreased from our 40 to 60 mLs. But at this point, it's irreversible damage isn't present yet. All right. So again, time is tissue, and we need to get them to the stroke center. When the cerebral blood flow drops to 15, 18 milliliters per 100 grams of brain per minute, the brain becomes electrically silent, and that means it's not going to communicate. The neurons aren't going to communicate with each other. The neuronal membrane is intact, but the functionality is there, but the activity due to the low cerebral blood flow is not allowing that those processes to work and communicate. So that area of electrical silence produces that neurological deficit. The brain cells are viable. They'll continue to try to function. You have some ATP production, but we're losing, we're against the clock. We got to get them fixed. Again, when the cerebral blood flow then now falls below 10 milliliters per 100 grams of brain per minute, we actually have rapid depletion of ATP. When our ATP decreases, we lose our sodium-potassium pump. In the cell comes calcium. Calcium is a strong component to draw in sodium, and with every sodium comes 3 water molecules. And so what happens to the cell? That cell swells. It starts to lyse, and then when it lyses, it actually will have acidosis, and then it'll die, and the lysosomes will go out and start attacking other things, other good cell membranes as well. The duration of occlusion to critical and neuronal survival, is the irreversibility of defects, right? We want to reduce the amount of infarction as much as possible, and we want that 3-hour window to maybe 6-hour window if we're talking about TPA. We hit on this early in the lecture, but I do want to go over it again. Ischemic stroke and atrial fibrillation, we talked about you have that embolic formation again, and I'm going to keep drawing this heart because I think it's that important. You have your left atrium, and when you have ectopic excited cells in your atrium, you actually start to cause a swirling of blood. And when that turbulence of blood comes down, it's going to go through the left ventricle and go out to the aorta and then to the body. Sorry, I don't have this flat, so I'm trying to write on an upright screen. And then the path flow, let me see here. So this is your heart. Your aorta will come up from your left ventricle. And then here will be your aortic arch. And then what you'll have is, let's just say, a carotid artery. So why we keep saying AFib and clots? Because if this clot forms and it goes through the aorta, this is extremely high pressure. This pressure is going to force up the pathway of least resistance straight up into the internal carotid, to the common carotid, into the internal carotid, and then go right to your brain. It takes more effort for this clot to actually go around the aorta, down to the descending aorta, and then go to the body than it does for it to go straight up under high pressure into the brain from the carotid artery. So, getting rid of some of the scribble in here. AFib patient is 5 to 17 times more likely to develop a stroke than a non-AFib patient, right? And then approximately 20% of all stroke patients had AFib on admission. You think to yourself, well, that's interesting. Is that why AFib patients are on Coumadin? Yep, that's why AFib patients are on Coumadin, because we want to prevent those platelets from sticking together. Strokes that are associated with AFib are likely to involve larger cerebral vessels. We'll see that later in my PowerPoint. They'll be more severe and they have a higher mortality. Again, because we're taking out, if this is the brain tissue and I take a coronal section, which means this is my brain, okay, and I slice it here, I'm looking down upon it, and let's just say this is the left, this is the right. And so my internal carotids will come here, and then they'll branch out to the middle cerebral artery, and then they'll branch straight up to the anterior cerebral artery. So if I have a clot here, what is not perfused? This whole area is not perfused. That's why. When we talk about lacunar strokes, those are small vessels. Those are going to be the terminal section of the area, and they're more common in African Americans, diabetics, chronic hypertension, again, because of the primary or essential hypertension. That's just genetically what they are. They're subcortical, they're well localized. They typically don't have any cognitive defects. They typically don't have any aphasia. Typically, they don't have any neurosensory motor findings, and there's no loss of consciousness, and there's no memory impairments. It's going to be kind of a focused area. Hypertension, obviously, hypertension will cause some thickening of the tunica intima, and then you're going to have that elasticity, and you're going to have that build up over time, and you're going to narrow that vessel. And as the vessel narrows, you're going to have more pressure come behind it, and so that's going to reduce cerebral blood flow, and you're going to have predisposition to thrombosis. And so when that clot forms, because what do we have in a normal blood flow? We have linear blood flow, but when we take that and we make it smaller, we're not doing as much. We're not having as great as flow, and so this blood will start to become turbulent, and then what happens? You stick, and then you form a clot, and that gets worse. With the anterior circulation stroke, we're talking about the front aspect of the brain. It perfuses 4/5 of the brain, the cerebrum and the cerebral cortex. These will originate from the carotid arteries. Normally, you have paralysis and motor function deficits. You have some weakness, some clumsiness, some heaviness of a leg or an arm or a hand on the face of one side of the body, unilateral. All right. If more than one area is paralyzed, it'll be all on one side of the body. And again, I'm going to show you a cartoon illustration to kind of show you that. If more than one area is paralyzed, will most likely involve the hand and the face. Good to know. And then involved body parts are opposite side of the lesion of the brain. So the left side of the brain affects my motor function on my left arm, my left side of the body. The left side of the brain affects the motor function on my right side of the body. Anterior circulation stroke, you can have numbness, tingling, and those are subjective. And what do we mean by subjective? That's somebody's perception. I think my arm fell asleep. Oh, can you be more specific? It just doesn't feel right. It feels like pins and needles. So that's how they describe it. And that's what we got to take their word of. But when we have loss of sensation, can you feel me touching, or are you not moving? We can objectively see that. All right. So that will usually occur in the hand, the arm, the leg, or the face. They'll all occur on the same side. If I have an occlusion to my middle cerebral artery on my right side, the left side of my body will not, in that region, will not act right. Multiple areas, though, will most commonly involve the hand and the face. Occurs at the same time on the same side of the weakness, all right? And again, the involved body parts on the opposite side of the lesion of the brain, as we just talked about. When we have language disturbances, we're talking about aphasia. So there's two types of aphasia. One is receptive and one is expressive. With receptive aphasia, they have trouble understanding spoken language. They can't follow verbal or written commands. With expressive aphasia, they have trouble selecting the correct words for speech or writing. The words may be spoken clearly, but they're incorrect or nonsensical. So here's kind of, again, sorry about the illustrations, but I think it's important. So this is your brain. And so if you've ever heard the term Broca's aphasia or Wernicke's aphasia, Broca's aphasia is due here. So Broca is broken speech. I have trouble understanding or following commands. So that's your Broca's aphasia. Wernicke's is this part of the brain on the side, and we say Wernicke's is a word salad because the expressive aphasia, they're spoken clearly, but they're incorrect or they're nonsensical. They're just talking about random stuff. I can hear the articulation of every word being said, but it just doesn't make sense. You ask them what time it is, and these patients kind of like act like a schizophrenic because they're talking about everything and everything, but not answering what time it is. The dysarthria is the act of pronouncing things is not as common with this. You could have agnosia, which is without knowledge. The patient won't be able to name common objects. You'll see, hopefully we get to it in our VAN assessment, that you're going to ask a patient to name two objects. And what do we usually have on us? We usually have a phone or a watch, and we always better have a pen, right? So you hold your pen up and you say, what is this? And the patient should be able to say pen. You should point to your watch or point to your phone and say, what is this? And the patient hopefully should be able to say it's a pen, or it's a phone or a watch. So what's going on with that is the connection between the visual interpretation of the object and the words that name them is damaged. They can't process that. So the misfiring of the neurons between the occipital and temporal lobes aren't working. And so you start to get the agnosia. The apraxia means without movement, and that's the inability to know how to use the object. So if I give the patient a pen and I say, write your name out for me, they won't know what to do with the pen. And so that's the misfiring of neurons between the temporal lobe and the frontal lobe. So again, just some common things I kind of told you already how to use it. You might have one without the other. You could also have binocular blindness, and so that's total or partial vision loss in one eye. It doesn't hurt, it's painless, and that can be from an ocular stroke, which is, the ocular artery goes in and it just kind of, the thrombus just goes there and it takes it out. You can also have a dropped curtain. It can be foggy, it can be grayed out, or it can just be black. And again, with this, the eyes are with the same side of the lesion of the brain. Anterior circulation stroke, again, external ocular movements remain normal, and so they're able to move their eyes. There's no double vision. That's what diplopia means. There's no dysconjugate gaze, which means that one eye does not look the same way the other eye. And there's no ocular palsy, which means that they have trouble moving their eye. There's no ataxia, and there's no vertigo. With a posterior circulation stroke, it does the 1/5 of the brain and supplies the brainstem. With this, you'll have paralysis, you'll have weakness, clumsiness, heaviness, or complete paralysis of a hand, an arm, a leg, face on one side of the body, or it could be both sides of the body. If it's more than one area is paralyzed, you'll actually have a common involvement of the face on one side and the arm, hand, leg on the opposite side. So let me repeat that a little bit slower. If more than one area is paralyzed, most commonly will involve the face on one side and the arm on one side. The face on one side, and then the arm, hand, or leg on the opposite side of the body. So the left side of the face might be droopy, and the right hand may not work. The right arm may not raise. Okay, that's posterior circulation stroke. Posterior circulation has to do with the brainstem, and that's our cranial nerves. All right, so that's important. If we had more time, I'd go through the cranial nerves, but we're running low on time. Involved body parts are on the same side of the lesion of the brain. Okay, these might present as drop attacks. Okay, so the patient's walking, they have a stroke, they just fall to the ground. Their leg's not working, their arm's not working. Language disturbance. Aphasia does not occur in the posterior circulation stroke. Dysarthria is much more common in posterior stroke. You just can't get out what you want to say. And normally that's because of the facial nerve, which is cranial nerve number 7. That is in the midbrain pons. That's in the pons. That doesn't work. The monocular blindness is rare, but your external ocular movements are impaired. So interestingly enough, the lateral rectus of the eye, this is your nose and this is your eyeball. If I look laterally, my eye is looking this way. That's done by the lateral rectus muscle that turns your eye out laterally. That's done by cranial nerve 6. Let's see, LR6SO. Supraoptic allows us to kind of look up. That's cranial nerve 4. And every other aspect of the eye, including your eyelid, is done by cranial nerve 3. So LR6SO403 sounds like something from chemistry, but with our eyeball, we get a posterior circulation. And again, you have your midbrain, your pons, and your medulla. And so what happens here, midbrain has cranial nerves 1 through 4, the pons have 5 through 8, and then the medulla will have 9 through 12. So what did we take out? We took out the medulla, we took out the medulla again, and we took out the pons. So when you have a posterior circulation stroke, it is common to have eye involvement. You can see this guy here, his lateral rectus of his left eye is not working. So I automatically know that that's going to be lateral rectus, which is like cranial nerve 6. I already know he has a Pons stroke in the brainstem just by doing that. And again, as we develop more lecture series, we're going to talk about all of this stuff in more detail outside of the EMS continuing education refresher. But you're going to have double vision, because if I'm looking at you and my eyes looking the other way, I'm going to see two of an object. Ocular palsy, which means I can't move my eye. Disconjugate gaze, one's looking at you, one's looking the other way, and the images might look bouncing or moving. Again, this is supposed to be a girl standing in one position, but because of how they're looking, you actually see multiple of them. All right, so you can have ataxia with a posterior circulation stroke, which is poor balance, stumbling gait, staggering, loss of coordination. You can also have vertigo, which is a sense of spinning and swirling that persists. Okay. Differentiate between lightheadedness and giddiness. Okay, like I feel lightheaded. That's not really a sign and symptom of stroke. But if you have vertigo where you feel like you're spinning, you need to really consider other aspects of your assessment to see if it's going to be a posterior circulation stroke. General signs and symptoms of a stroke. You're going to have obviously the facial drooping, the headache, the aphasia, dysphagia, the hemiparesis, the hemiplegia, paresthesia, which is like your pins and needles, your numbness, your gait disturbances, incontinence. 5 to 7% of all strokes actually have a seizure. Those are going to be your signs. Your symptoms, they're going to be confused, they're going to be agitated, dizzy, and they're going to have some vision problems. All right. Hemorrhagic stroke overlaps a lot with ischemic. They generally appear more ill, they deteriorate more rapidly, and they present with more severe headaches. They're going to have marked disturbances in consciousness, and they're going to have more severe nausea and vomiting. Again, we talked about the subarachnoid, the worst headache of my life. It occurs suddenly. During exertion, rapidly reaches the maximum severity very quickly. The pain is generalized around the head, and that comes down to the neck and to the face. May just be the headache and no neurological or focal neurological deficits. They're going to be nauseous, they're going to be vomiting, they're going to have intolerance to light and noise, and they're going to have some altered mental status, and they could have some nuchal rigidity. Be careful with the nuchal rigidity. Nuchal rigidity is also a sign of meningitis. All right, so I'm going to exit out of here and just see how much more Joe has. Joe, I might cut you short a little bit. So when we talk about pupils, the pupils is actually the dilation and constriction of the pupil is by ocular nerve 3, cranial nerve 3. That allows us to go ahead and kind of like accommodate to light. When you have reflexes that are not intact, you're going to have, what we would typically do is take a cotton swab and see on the corneal reflex if they're able to elicit a blink. And if the reflexes are done, that means they usually have a brainstem stroke, and it's a doom sign there. So obviously for our assessment, we're going to get the person who last saw them and get a phone number for that person. We're going to get the last time of last known well, or what's the last thing they were doing. If they woke up overnight, that doesn't matter. Put them in the back of the ambulance and go to the hospital, and figure out what from bystanders, coworkers, what's going on with the patient, if they have any sort of, excuse me, any medical problems, any medications, allergies. All right. Pay particular attention. This is key to anticoagulants, antiplatelets, because typically they will not be a candidate for TPA if they're already on something. Make sure you rule out diabetes. Take a BGO on that patient. Again, if it's less than 60, you better be treating it. And again, I need to emphasize that most of our glucometers in EMS are capillary glucometers, which means nobody on this call should ever be using the flashback chamber or venous blood in order to dab that onto a piece of paper in order to take the glucometer and get a reading from it. It's up to 20 points off. And again, if you remember the picture with the artery coming into the capillary going out to the vein, the site of capillary, which is going to be our fingertip, that's where oxygen and nutrients get offloaded. That's going to be your best measurement for your glucose. The worst thing you want to do is get a denutriented blood glucose reading from a vein, thinking that the blood sugar is, 50, give glucose to somebody who's having a hemorrhagic stroke, and in reality, a capillary reading would have showed 70, and that would have changed your treatment. Okay, So that's very important, very important. If you are in a large system that has a lot of people and a lot of money, you can actually have glucometers that would do venous and capillary blood. But typically in EMS, those are too expensive for us to have. All right, so I'm gonna stop here with this lecture, and I'm gonna bring up my lecture real quick. And what that's going to do is I'm going to take you through what the Cleveland region is doing. Coincidentally, is what we did research for, and we did our research, and we're going to start doing here. So again, when we talk about I know we're running a little bit short on time. Just give me a couple extra minutes, and I promise you it'll all tie together and it'll make sense. So I sound like Joe Mistovich now, but he's wordy. I'm not. I'm talking fast, so bear with me. So when we talk about the brain, we have all these different regions, and the regions of the brains are called cortex. And so when we typically talk about a stroke, we're going to talk about the primary motor cortex, which is right here, and we're going to talk about the primary somatosensory cortexes here. But we can see the prefrontal cortex in green here. That's going to do. We're gonna talk about neglect. All right. We can see that the back part of the occipital region here. The occipital region is our primary visual cortex. So with this, it actually goes up into the posterior parietal cortex, saying, I'm going to figure out where this object is. So right now, my Yeti cup is about 12 inches away from me. I can see that with my posterior parietal cortex communicating with my visual cortex, right? But what is that's 12 inches away? That's going to be right in this region of the brain from the primary visual cortex. And I'm going to say, that's a Yeti cup. And I'm going to communicate that with my posterior parietal cortex and say, that's about 12 inches away. In order to pick that up, I'm going to activate my primary motor cortex. I'm going to reach out and get it. And that's going to be pre-planning from my prefrontal cortex. So what I'm trying to say is every part of the brain works together to elicit a movement. Therefore, our stroke assessment has to rule out or include different parts of the brain to figure out where this stroke is. As Joe had on his lectures or on his previous slides, this is the circle Willis here, and this is what it looks like on the posterior side of the brain. So you're going to have your optic chiasm here that goes out to your optic nerves, and then these essentially would be your eyeballs, and that's going to come up. What I want you to focus on is I want you to see that we have our carotid arteries here. We have our anterior cerebral arteries here, which perfuse the front of the brain. We have our, let me see here, posterior communicating artery, which is here, all right? And we have our middle cerebral artery, which is coming off the carotid. This is the carotid. This is the middle cerebral artery. That's what we're looking for when we have a motor function deficit stroke. This is just an MRA, magnetic resonance, or angiogram of a circle Willis here, so you can see what this is on a real person. So this is our bread and butter of this lecture, is that when we look at different parts, all right, this is going to be the vertebral artery, the internal carotid artery, the basilar artery, the posterior cerebral artery, the middle cerebral artery, and the anterior cerebral artery. And let me go back, and you can see where these are this is the basilar artery here. So you can see how those kind of come into here to figure out what's going on. So our vertebral artery comes off of our subclavian arch, and it comes straight up, and that vertebral artery is going to merge with the basilar artery, and that's going to perfuse the back part of the brain, that visual cortex, or the bottom of the brain. That's going to be done by the vertebral, the interior, the basilar, and the posterior cerebral artery. Coming off of the common carotid here, you're going to see the internal carotid, and then you're going to see the MCA, and I trace that right back down here. Coming off of also the common carotid, you're going to see the anterior cerebral artery. Okay, so this is an inferior view of the brain off to the right. You're going to see this is going to be done by the posterior communicating artery. The front is going to be the anterior communicating artery. This is going to be the medial communicating artery. Middle communicating cerebral artery. My apologies. Okay, This is a side profile of the brain. So again, you're going to see the anterior cerebral artery is going to perfuse this light yellow-green area here. The middle cerebral artery is going to do mostly the whole side of the brain. And the back of the posterior region of the brain is going to be done by the posterior cerebral artery. If I take that brain and I cut it from the septum of the nose back to my vertebrae, I'm going to cut the brain in half and left and right. And what's going to happen is I'm actually going to see my corpus callosum here. My corpus callosum is what allows the left side of the brain to communicate with my right side of the brain. People who had personality disorders back in the 1800s, they would cut this. People who had seizures, they would cut this so that you couldn't have a right-sided seizure causing left-side stuff on your brain. So they would cut that. That's not done anymore, obviously. But you can see that if I open this brain up, I have more circulation from the anterior cerebral artery that I'm perfusing, and I have the posterior cerebral artery that's perfusing when I cut the brain in half. If I look from underneath the brain, I'm going to see that posterior cerebral artery does most of the bottom of the brain and just a little bit from the MCA and the ACA. This here is a homunculus. And so a homunculus is a cartoon representation. If I take my brain, and what I'm focusing on is that motor cortex that I showed you in the previous slide. I take my brain, and what I'm doing is I'm cutting it from ear to ear, and then I'm flipping it down onto the table. What happens here is I'm able to see which body parts of my brain is affected by which arteries perfuse that brain. So, for example, my leg, this is my leg, obviously, my toes, all the way to my trunk of my body, that is done by my anterior cerebral artery. So where I'm going with this is if I can't move my leg, I know, if I can't move my right leg, I know that the anterior cerebral artery of the left side of my brain is affected just by knowing this homunculus. Now, if I have facial droop, if I have arm drift, if I have anything with my fingers, I'm going to know that over here you can see what regions are affected by the middle cerebral artery. And that middle cerebral artery is going to do a large chunk of the motor function of our brain. The posterior cerebral artery, which is this shade in purple, I'm just going to have you say that's anything with eyes. That's going to be the easiest thing. That's the motor on the left. The sensory on the right mimics the motor on the left. So if I don't feel anybody touching my right leg and I can't move my right leg, it then makes sense that the left anterior cerebral artery is affected. They go hand in hand. And I'll post these slides so you guys can look at this even more. Again, this is another homunculus that's going on, but this will show you the blood flow distribution. So let's take a patient with a right-sided facial droop. With this patient with a right-sided facial droop, I know something. What do I know? I know that the patient probably has what? Here's facial droop. What is that perfused by? The MCA. Why? Because when I told you in 2, it's green. The MCA is affected. So here's a right-sided facial droop. I'm going to say, because this is the right, this is the left. I'm going to say it's going to be my right MCA. And I know from my previous slide that my MCA comes off of my internal carotid. So that's what I think is going on. I look at this and I superimpose an angiogram on top of that. And sure enough, look, there's a stroke right there. There's a stroke as it feeds up from the internal carotid with that right-sided facial droop. And again, what should be there? If I were to infuse IVP dye into this patient, I should see the ACA clearly and I should see the MCA clearly, but I don't see that on this patient. So when we look at the cartoon representation, and then when this patient actually had their their angiogram done, there was a clot right here with this green area. So what was this affecting? This is affecting not only the face, but also, what do you think else? If the MCA does the face and the hands, the ACA, we said, does the leg. The patient should also have leg, face, and arm problems. All right. So I thought that was cool to kind of include into there. So quickly, let's talk. We already talked about lacunar strokes. Lacunar strokes are anything here with the dots Those are end or distal terminal strokes because there's no other collateral circulation. If something goes in there and it blocks it off, that region of the brain, that area of the homunculus is affected. All right. It could be pure motor or pure sensory, but it's probably not going to be both. It can involve the face, involve the arm, involve the speech, but only certain areas. It's not going to be the whole side of the face. It's not going to be the whole arm. It's going to be very specific to where that occlusion is. It will not have the additional cortical involvement. And what I mean by that is you're not going to have eye problems on top of sensory problems, on top of motor problems, because it's a small stroke. It's a small vessel. It doesn't perfuse a large area of the brain. When we talk about slurred speech or the dysarthria or the ability to be articulate, slurred speech isn't really a good indicator of a stroke, because what if you're diabetic? What if you are drinking alcohol? What if you just did some drugs? What if whatever happens? Okay. Slurred speech is not what we're looking for. We're looking for that expressive and that receptive aphasia. So when we talk about large cortical strokes, we had already talked about that. Look, this is your MCA, right? If I take out my MCA, what is not perfused? This whole region is not perfused. So that's something to kind of look for. Again, this is your basilar artery, okay? This is going to be coming into your vertebral artery and your internal carotids. So our medium to large vessel arterial strokes are going to have more than one symptom. And what I'm teasing here, this Van mnemonic, is we're switching to the Van Stroke Assessment Scale, and this is why. The Van Assessment Scale assesses vision, aphasia, and neglect. So when we talk about vision, we're talking about, what did I say? We're talking about the posterior cerebral artery. And the vision is going to have a vision field cut. And I'll show you a quick little video of how that's done. You can have double vision, and you can have new onset of blindness. Why? Because we know that the posterior cerebral artery does anything with the eyes. So anything with the eyes that's wrong is a vision. We know it's probably going to be the PCA, and we know that this patient has a large vessel occlusion. Aphasia is either going to be the inability to speak, difficulty forming words, or that broken speech, for that Broca's aphasia, or they're going to be unable to be understood because they're going to have a word salad from that Wernicke's aphasia, right? And that's also going to have to do with either the brainstem or that's going to have to do with the MCA. Neglect is going to have to do the frontal cortex, which is looking to one side, forced gaze, pre-planning movement, or it's going to have to do with neglecting one side of the body. I can't feel somebody touching on one side, and I can't identify my own arm on one side. So why Van? Again, we're switching to Van for large vessel occlusion. Previously, I've known a lot of areas we're doing MEND exam. This is why. Vision does the vision cortex. The aphasia will do the middle cerebral area here. The neglect will do prefrontal cortex with planning, which means your eyes will be fixed. And also the motor and the sensory region is also neglect. Again, I feel the right arm. I can't feel somebody touching me, or I can't identify my right arm because I'm neglecting that whole side of the body. This is why Van is up and coming. But we need to have a little bit of a paradigm shift. So just like we activate the cath lab in an MI, we're going to activate the stroke lab or the interventional radiology team suite for a stroke. So for non-STEMI, what happens? You have ST depression, the patient goes in, you follow ACS protocol, you're giving aspirin, you're giving nitro, maybe gets better, but these patients don't have ST elevation, so they're going to get a little bit of treatment, maybe some Plavix. If you have a STEMI, well, now you're giving aspirin, you're giving nitro, and you're calling in early, and you're giving the order to activate the cath lab. With a stroke, I want you to use that same comparison. Non-STEMI is to non-large vessel occlusion stroke. And STEMI is the same as a large vessel occlusion stroke. So non-STEMI, medical treatment, medicine. Non-large vessel occlusion stroke, TPA is given. A STEMI, we give aspirin, we go in for the cath lab. Large vessel occlusion, they're still going to give some TPA. They're going to go into endovascular thrombectomy at a comprehensive stroke center, which is Cleveland, Pittsburgh, Columbus, Toledo. And they're going to go in and they're going to retrieve that clot. So very quickly, I want to talk about some sort of stroke scales, and then we'll wrap things up. So before I talk about the Cincinnati Pre-Hospital Stroke Scale, I want to talk about what tests mean. And so with this, we need to understand two terms. We need to understand sensitivity, and we need to understand specificity. In the medical world, sensitivity means the ability of a test to correctly identify those with a disease. So the more sensitive a test is, the more likely that patient has a disease. With specificity in the medical world is the ability of a test to correctly identify those without the disease. So a test that is highly specific rules out the disease. A test that is highly sensitive says that they have the disease. So here's an example. If 100 patients known to have a disease were tested and 43 test positive, then that test has a 43% sensitivity. If 100 patients with no disease are tested and 96 return a completely negative result, we're ruling that out, they don't have it, then that test has a 96% specificity. All right? Sensitivity means they have it, specificity means they don't. So let's talk about the pre-hospital or Cincinnati pre-hospital stroke scale. What does this entail? We're going to look for a facial droop. Can they smile equally? We're going to assess for arm drift. Have the patient close their eyes, hold their palms up for about 10 seconds, see if one of their arms drift. We're going to have them repeat a phrase, and most historically, you can't teach an old dog new tricks. If the patient slurs their speech, then we said, or they have any of these, then we say, hey, look, the Cincinnati pre-hospital stroke scale is positive. I think the patient has a stroke. If any one of these three signs is positive, the likelihood, the probability of that patient having a stroke is only 72%. We don't know for sure, but it's 72%. When I was researching articles to figure out the specificity and sensitivity of these things, remember, sensitivity means they have it, specificity means they don't. The Cincinnati pre-hospital stroke scale was only 61% sensitive in saying that the patient had a stroke. It's not very good. It's not very good if we're going to go ahead and activate the cath lab, get a CT machine ready. We need to do better. And if this is all normal, we rule out up to 96% of the time that this patient does not have a stroke. So it's good for ruling out, not very good for ruling in. But what this stroke scale doesn't do, it doesn't measure severity, and it doesn't assess the posterior circulation because it has nothing to do with eyes. So, we've been doing it because it was easy, but I think we can do better. Then they took it one step further, and they said the Cincinnati pre-hospital stroke severity scale. And with this, you're still kind of doing the same. You're talking about, we don't use this, but you're talking about a conjugate eye gaze, and we said that was done in the prefrontal cortex because that was pre-planned motor. Loss of consciousness and ability to obey commands. So that's going to be the ability to understand. Then we're going to talk about, are they able to hold their arm up? And that's going to be the motor cortex. And then can they speak? And that's going to be the Broca's area. But look at this. You had to have some sort of scoring scale. Who, in their right mind, going 60 miles an hour down the road on average, on a side street, is going to be able to calculate that before they get to the hospital? You're not. So this is not very good. And for a long time, this whole area, from Cleveland all the way down to Youngstown, has been pushed with multiple protocols to say the MEND exam. The MEND exam, the problem with the MEND exam is it tested the same thing multiple times. Why are we retesting things multiple times? And I'm going to give you an example. So remember that this is your homunculus, right? And, whoops, that's a triangle. That's not a circle. This is your homunculus. And so, still like a triangle. There's a circle. There you go. Okay. So we said what? We said the anterior cerebral artery was going to do the leg. So I'll put the trunk and the leg, right? And we said that was true for both motor and sensory. And we said that the arm in the hand and the face was done by the medial cerebral artery. When we come over here to the MEND exam, not only was it lengthy, but look what we just did. We assessed motor function, we assessed sensory function. And guess what that did? That took time up because all it did was retest that same artery. If I can't move my arm, I probably don't have sensation on the arm. So I wasted time trying to figure out the large vessel occlusion by retesting the medial cerebral artery. This was good because it incorporated a lot of things. You already had your Cincinnati pre-hospital stroke scale by here, here, and here. But now we retested and we wasted time. The other interesting thing about this, the more positive you have of this stroke scale, the less sensitive it becomes. How about that? If I have multiple check boxes on this, I only have a 60% of saying that's a stroke. And I only have a 65% of saying that's not a stroke. So we've used this. I was taught it back in paramedic school in 2007, but now, because of evidence, because of research, we're moving away from it. This is why we're moving away from it. What are we moving to, Van? We're moving to the vision, aphasia, neglect score. So why are we moving to it? There's no calculation in numerical score, and it reduces the observer differences. What that means is I might say, the left side of the face doesn't look drooped. And the nurse might say, oh, it's definitely drooped. And I've had that personally, and I'm sure you guys have too. It's like, I don't see any facial droop. It's like, oh yeah, they definitely have facial droop. So that's one reason. The other reason is we use a motor weakness as a central triage score. So what we're going to do is we're going to do our FAST exam, and I'm going to show you a little protocol page. So we're going to do the facial droop, the arm drift, the speech, and we're saying this is test. We're not saying this is time. So we're saying that's test. If they have facial droop, okay, we can say that might be a leukemic stroke. If they have arm drift, we know that's motor. What do we say? We know it's motor. We got to test which large vessel it is. So if they have an arm drift, we're automatically moving down to Van. If they don't have an arm drift, we're not doing Van. It's that simple. So here's what I'm telling you. They have facial droop or they have speech deficit. It's a lacuna stroke. They have arm drift. We're looking for a large vessel occlusion. And that's as simple as it is. All right. So Van also teaches what you're looking for, vision, aphasia, neglect. So let's get into it. Again, vision, aphasia, neglect, VAN, and that's the areas we're curious about. We want to know what part of the body they can't move. We want to know in the sensory what part of the area they can't feel, but we're doing that with one assessment tool. All right. We want to look at the eyes to see if they have field deficits, left or right. They can't see left or right or medially, and we want to see if they have a gaze. So here's what we're going to do. We're going to conduct the FAST exam. If there's an arm drift or weakness present, we're going to go directly to the Van exam. We're going to test the visual field. All right. So we're going to say, hold 2 fingers up, and we're going to have them look at your nose. And you're going to say, how many fingers do I have on the left side? 2. Make sure they're looking at your nose. Change the number. How many fingers do I have on my right side of your face? 3. Okay, cool. Visual field test is okay. We move on to aphasia. If the visual field test is not okay and they have difficulty seeing, then that's Van positive. You're done with the stroke scale. We can say with almost certainty, almost 100% of the time, where that stroke is. And if I have a Van, it's probably going to be the posterior cerebral artery. Done. I'm going to test aphasia. Aphasia is probably going to be done by the middle cerebral artery. I'm going to ask the patient to identify 2 objects. What's this? It's a pen. What's this? It's a cell phone. Can you obey my command? Can you close your eyes? Can you make a fist? And can you repeat a phase? Today's a sunny day. Not in Northeast Ohio, but today's a sunny day. If they can do that, most likely it's not, well, I can't say that, but most likely it's not the speech centers. And so it's going to be okay. If it's positive for anything, then it's going to be Van negative. And I'm going to say it's probably, if it's speech related, it's probably going to be middle cerebral artery. We're going to test neglect. And with neglect, if a patient has a forced gaze, that's the frontal cortex of the brain that I said. If there's a frontal cortex problem, that's going to be done by the anterior communicating or anterior cerebral artery, and they cannot track a pen, just like you see a field sobriety test. Follow my pen. They should be able to look to the left. They should be able to look to the right. If they can't do that, or if they can't feel you touching one side of the body or unable to identify their own arm, that's positive. And so we would see which part of that would be. Would it be a leg? Would it be an arm? And that's going to distinguish between an MCA and ACA. But what are these? These are large vessel occlusions. So we are close to 100% of the time saying this is a large vessel occlusion stroke. We are up to 90% of the time saying this is not a large vessel occlusion stroke, if we can rule these out. That's why we're going to the Van assessment. So Trumbull Regional Medical Center pre-hospital emergency medicine protocol for stroke. Again, nothing really has changed, but what we are incorporating is that Van exam. We've taken out MEND exam in Cincinnati pre-hospital. Universal patient assessment, assess the airway. Again, check the VGL early. If it's less than 60, go ahead and 60 by capillary. Again, that's important. Go ahead and get some glucose, reassess. If the glucose is normal and the patient is still presenting like a stroke, it's probably a stroke. Perform the FAST exam. If you have a positive arm, so I'm just going to say if you have a positive arm, anything, weakness, drift, paralysis, then you're going to move on to the VAN exam, and you're going to see, you're going to assess the vision, the aphasia, the neglect, and get on, try to do a 12 lead, see what's going on. Notify the facility early. I don't care where you are in the state of Ohio, Pennsylvania, West Virginia, if you're coming from, the planet of Pluto. Notify the facility early. As soon as you figure out it's a stroke, you better be on the phone or using the Triage app or whatever app you use, Pulsera, to notify the facility you have a stroke. Okay? Again, in the Youngstown, Trumbull County, Mahoney County, Columbiana, Akron, wherever, we don't have a comprehensive stroke center, unless I'm mistaken, but the last map I found said Cleveland, Pittsburgh, Columbus, Cincinnati, and Toledo. Take them to a primary stroke center. It's important. In Ohio, legislation is drafted and ready to be voted on and probably going to go into law that just like trauma triage, we have to take them to a trauma center. We will have to take anybody presenting with a stroke to a primary stroke center. So that's coming. The primary stroke center in the Youngstown area, where we're hosting this from, Youngstown, Warren area, is Mercy Health Youngstown, St. Elizabeth's, and then Trumbull is diligently trying to work on a primary stroke center as well. So you'll have one in Trumbull County, one in Mahoning County, so you guys can take them to a primary stroke center. The responsibility of that primary stroke center with EMS help is to get them to a comprehensive stroke center if they have a large vessel occlusion. So that's why it's important. If you call St. E's, you call Grant Medical Center or Ohio State Medical Center or Cleveland Clinic or UH or St. Vincent Medical Center or UC Cincinnati, and you say, or UPMC and WVU, and you say, I have a positive VAN stroke assessment. If they're not a comprehensive like the ones I just listed, they should have a bird in the air to transfer that patient to a comprehensive stroke center, which are the areas that I named. All right. Rapid transport. So go ahead, 24 hours. You know what? Just make it. Anybody has signs and symptoms of a stroke, run them right to the hospital. Let the neurologist figure it out, because these patients can present up to 24 hours with no deficits when they go then do the endovascular thrombectomy. So what we're doing, again, we already talked about this. We're going to do a FAST exam, right-sided facial droop. So this is a FAST exam, face, arm, and speech. Do they have right-sided facial droop? Yes, no. Is it normal? We're going to go to arm. If we have a positive arm, I don't care about speech. We're moving right down to VAN exam. If they have a normal arm exam, normal arm, I'm not doing this. Okay? So again, if the arm exam is positive, meaning I have some sort of deficit on my arm, I'm skipping speech and I'm going to my VAN, and I'm only doing whatever I find positive. If I find visual disturbance positive, I'm stopping with the rest. If that's normal, then I'm going over here. If this is normal, then I'm going over here. All right. If arm is normal, there is no reason. If this is normal, I don't care about this. Chances are it's not a large vessel occlusion stroke. So I'm not going to show you a video, but what I'm going to do is I'm going to put that onto the Google Classroom so you guys can see what we have going on.